Good morning, everyone. My name is Dr. Angela Webb, and I'm the Director for Health and Family Services here at North American Management. I want to thank all of you for participating on today's call, which we have scheduled in order for you to better understand how HRSA and ACL grantees are working together to improve the health care of seniors in disadvantaged communities. I would first like to acknowledge that we do have the ACL administrators, AOA administrators. We have state units on aging. HRSA is on the call, health center programs, and primary care associations. So we're really delighted that all of you can join us here for our regional call for Regions 2 and 3. These include the states of New York, New Jersey, Puerto Rico, D.C., Delaware, Maryland, Pennsylvania, Virginia, West Virginia. And we have all of you join us today from both the aging networks as well as the health center programs and primary care associations. So we would like to, first of all, give you a brief overview of who we are as a national corporate agreement so that you have better understanding of why we have scheduled today's call. North American Management has a project called the Health and the Aging Project, which is a national corporate agreement that is managed by North American Management. In September 2001, we commenced this project in order to provide training and technical assistance under a grant awarded by the Department of Health and Human Services, Health Resources and Services Administration, HRSA, to aid health centers to increase their capacity to serve the aging population. North American Management provides support to health centers to provide assistance in all of the 19 program requirements that the health center programs are required to have. In addition to that, as a national cooperative agreement, we work in close collaboration with our primary care associations, who are also funded by HRSA to provide training and technical assistance for our health centers. HRSA and the Administration for Community Living have been working together for many, many years. And through our recent award last year in 2011 for the corporate agreement, we have been able to provide even further collaboration efforts in order to connect both the ACL as well as the HRSA grantees. One of the reasons that we know that this is extremely important is that our community health centers are seeing a significant number of seniors who live in underserved populations. These are not only our special populations, but also the disadvantaged populations. The health centers themselves are funded by HRSA to make sure to provide access and quality care for these residents, the homeless populations, the migrant populations, and all of the populations who live in disadvantaged communities. Many times in the regions, as they're working with the senior populations, there are a number of unmet needs that are identified. So I would like to give you a quick overview of what's happening in Region 2 and 3. Right now, there are approximately 52 community health centers that are serving seniors in Region 2. And we have in Region 3 approximately approximately 110 community health centers. And I will correct that. For Region 2, we have 94 community health centers who are serving seniors. These community health centers serve a total in Region 2. The number of patients being served are approximately 2,313,000 patients. In Region 3, approximately 2,747,000 patients are being served by these community health centers. Now, the total number of seniors, those are the number of patients. The total number of seniors being seen by both populations is approximately 300,000 patients. So we know that there are significant numbers for those of you, especially in the aging networks, who know that there are a tremendous more number of seniors in your regions. There are a total number of unmet needs happening right now. And our purpose of today's call is to not only learn about how community health centers can provide that medical, clinical care, primary care that the seniors need, but also how the non-clinical and social needs can be met through the partnership with the aging networks in your areas. So I'm going to ask one of our community health centers if they would to first of all present or a little bit about some of the work that they are doing to meet the needs of seniors in their patient population. So I would like to invite Dr. Rena Ramirez, who is the Chief Medical Officer at Sioux Falls Health Center, and she will be delighted to give you some little insight of what's happening with her community health center. Dr. Ramirez?
Thank you, Astro. Good morning, everyone. As Astro mentioned, I'm Rena Ramirez, and I am the Chief Medical Officer at Sioux Falls Health Center. We are a federally qualified health center that have been so certified since 2004, but we've been in our community for longer than that. We serve the Northwest New Jersey area, including 4 counties, counties of Sussex, Warren, Morris, and Hunterdon. And we began as a small center in working in a community church basement in 1990 when Dr. Sufal and his wife decided that after they retired, they needed to do something for their surrounding neighbors. With volunteers, they really developed a wonderful access to patients who were in the Dover area, and that grew and grew until we actually were able to become an FQHC in 2004. Right now, we have, as I mentioned, we're covering 4 counties, and we have 4 sites. One in Dover, our main site, one in Morristown, one in Hackettstown, and another which is our mobile medical van, and it's a licensed medical facility on wheels. We also have plans to go to Flemington and open a dental clinic this year. So we have a lot of exciting things happening here. And we also have expanded our reach to serve the homeless, residents of public housing, and farm workers. And as Astro mentioned, our focus has also been on our seniors. In 2011, we served over 15,000 patients and had over 45,000 visits, and the majority of those are under 90% and under 200% poverty level. 70% of them are uninsured, and the majority of our patients are Hispanic. Most of our patients are adults, and 60% of our patients are seniors. And these are mostly residents of public housing, and this has been an interesting experience for us to reach out to our seniors. One of our challenges, and I'm going to go immediately to some challenges, is that of our seniors, only 50% of those are insured or insurable. And many of those that are insured do not qualify for Medicare. So again, we have some of the access and resources issues starting from the get-go. To let you know a little bit more about our center, we are open 7 days a week. We have late hours at most sites, and we work on Saturdays and Sundays. We have 24/7 bilingual coverage with providers on call to answer any needs, any questions. And we provide services ranging from pediatrics all the way to geriatrics. We also have a Ryan White program. We have dental. We have podiatry, behavioral health. We have clinical pharmacy services, which is one of our STAR programs. We have patient navigators who are wonderful, case management, 340B pharmacies, support groups, and a new veteran outreach program, which we're very excited about. We got that through a collaboration through the NJPCA. We serve residents of public housing on all our sites, but the one that's really a stellar site is our Morristown site, and it is just one block down from two residents of public housing areas, and it was just wonderful how during Sandy, when we lost power, we decided to go ahead and continue to see patients at that site using our mobile medical van. So we try to do our best to serve our patients in every which way. And this was, again, something that we need to do all the time because our patients are so needy. Some of the highlights of our programs regarding our seniors has been a senior group. We had a Live Your Better Life program funded through the Grata Foundation, and it was just an absolute need. I saw it through actually my patients who I saw were isolated, disenfranchised, had no one to speak to during the day because their adult children were out working, and I realized that we needed to have both a support group for our seniors to empower them to take care of themselves, to have others to be with, and also to help the caregivers because it is quite a big challenge on them. One of our senior, the child, or I guess an offspring of ours, he's not a child, he's an adult, but he came up to us and said, after my mother went to the senior group, she has been transformed. She is happy, outgoing, and taking charge of herself. So this is the kind of stuff that we really, really, just value and love. We also have a breast patient navigator program, both through the Komen Foundation as well as through the NJC program, and it's been absolutely a gem because we have identified, our navigators identified that there were no support groups for women with breast cancer or survivors of breast cancer west of Summit who spoke Spanish, like a Spanish-speaking group. So we developed that one through some funding, and we recently got three seniors joining our group, two of them who are not even our clients, but will accept everyone from the community to serve them in terms of support regarding their breast health and what they're going through. One is under treatment, the other one is in remission. So it's just really, again, some special things that we do that I think through community-based organization partnerships we really have had some successes. Another very important need is, and that we are addressing, is dental care. We use our van to go out to nursing homes and to the public housing areas, and we have screened and treated over 40 seniors so far in 2012. These are treatment programs that we actually go, the dentist and his staff goes to the site and have with scheduled visits and does follow-up checks and complete treatment plans for these patients. Another thing that I mentioned, and I think it's important, is our clinical pharmacists. Seniors with medications are at the highest risk in terms of having safety issues, adverse events, hospitalizations, and even deaths. And we recognize that from the beginning. So our pharmacist, who is a part-time pharmacist and a full-time person here because she helps me with quality assurance, provides individual and group counseling sessions to seniors, to any patient who has complex conditions, multiple medications, and is high risk. So this is something that is really has worked to increase the safety and increase the and improve the health outcomes of our patients, including our seniors. We've had all these successes because of some community partnerships that we've developed over the years, and it is so gratifying to hear Dr. Webb talk about all the other available services and resources that are out there. We have had partnerships through pharmaceutical companies who have given us funding to help with the pharmacists. We have wonderful pharmacies who partner with us through the 340B program to increase access to medications to everyone. We've had a relationship with the Rural Health Policy New Jersey State program for our patient breast health navigation, and the Komen Foundation, as I mentioned. We have pharmacy students who help us provide patient education and medication reconciliation. Is that when you have your seniors come in with all their medications, figure out what they should be taking and how, and safely, and that they come through the Rutgers School of Pharmacy, and many, many others. We have the Morris County Organization of Hispanic Affairs down the street who provides transportation for our seniors and eye exams on a monthly basis. So it is a collaborative agreements, and it's through collaborative partnerships that we've really been able to achieve a lot of our successes and to develop these services for our seniors. Last year, we were fortunate to get a grant from the New Jersey State on MIPA, which is the Senior Medicare Program as well, and that was a very, very good program for us because it really did have an impetus for us to go to outreach to seniors and explain how to sign up for the Medicare Part B, and to explain to them the benefits in the new Medicare law, including the preventive health examinations that are available to them. We go to the lunch program in the senior public housing. We have also a focus on seniors through our Patient Safety and Pharmacy Services Collaborative. We have over 50 seniors that we follow on a monthly basis to make sure that their diabetes is well controlled or they're not having any issues with it, and those who are on anticoagulation, which is a very, very dangerous drug, are using it properly and are not having any adverse events. So again, we have quite a few, and these programs are intercalated and integrated into our general program. So our seniors are part of our general group, but we have special activities that I think really just address their specific needs. So what are some of our challenges? Well, client-specific challenges include that our patients are uninsured, as I mentioned, and many of those are undocumented seniors. So therefore, they're not really eligible for services, or may not be eligible for services. I'm not saying that they're completely not eligible. Some of our community-based organizations and agencies do provide services regardless. They have significant depression and isolation issues, are dependent on their adult children, and really don't have any other outside social life. So that's why we'd address the support with the support groups and other activities. They have low health literacy, and even in their native language, so that when they do confront the health system here in the United States, it's very confusing and could be completely daunting. In addition, they have very low income and inadequate housing. One of our diabetic patients who was not doing well, we couldn't understand why, and she was living in a very hot one little room, and we found an air conditioner for her, and she was just so happy, and it made such a big difference. In terms of center-specific challenges, again, we have a lot of funding, and that's wonderful. However, the enabling services are not directly funded, and the manpower sometimes just gets stretched out thin. We do have a lack of knowledge of the programs available out there and what eligibility requirements are there. So again, this is a wonderful call for us to really get hooked in together with what there is available so that we could have linkages. In addition, we have a narrow view of our patients. We see them from the provider perspective and the healthcare perspective, and the agencies out there see what the needs are, their food, the clothing, transportation, and all that. So those are the things that I really, wanted to point out as challenges. But what are we doing about it? We're going for patient-centered medical home transformation, and that is something that has really made the primary care experience, I believe, improved it significantly. We have teams, and the patient sees their doctor and their team, and they become comfortable and gain trust in coming to our center, so that the care management becomes more seamless, and the patients benefit in terms of health outcomes. Our support groups have been very successful, and we've gotten volunteer exercise physical therapists to come help us, and we do chair yoga. In the breast cancer support group, we are doing relaxation yoga with the women who participate, and it has been a complete success. Our patient navigation services are so important in helping patients with this very specific issues, and this has been a tremendous plus for our patients of all ages. And access to care is another thing that we do. That's how we engage patients. We bring the care team to the patient. This is really a major, major focus of one of the successes for especially dental. We have gone to and as well as medical. We go out to the soup kitchens every week. We go out, we take a nurse practitioner there. We go to Salvation Army, senior centers in Riverdale, Morristown Housing Authority, the churches in the areas that we serve, Club Colombia here in Dover, Morris Hills Assisted Living, Parsippany Senior Center. We bring the services to the senior. And that, to us, has been a tremendous success, because then they get the services they need without having to disrupt their lives or go to transportation issues and whatnot. The progress towards expansion of senior services here at Sioux Falls Health Center, as I mentioned, is the PCMH approach. Is we want to continue with the one-stop shopping of what we can provide, of the medical services that we can provide. Primary care medical services, dental care, lab services right here on site, behavioral health, the support groups and the navigators, podiatry, and more. In addition, we have plans to expand our services, including adding a neurologist so that our seniors can be evaluated and followed more closely for dementia and balance disorders, nutrition, eye exams and hearing tests within our center. We're looking at all that to see how we can get this right here so that seniors have everything in one place. And my wish list is to also have a patient navigator for seniors. So that person will be a natural linkage between the health center as well as all the other agencies that are available out there to help us. So that partnership and that linking is so key, and is something that we are looking forward to. We've already began to develop some of that. We met last week with the Veterans Directed Home Community-Based Services, which is part of the AOA, and we are very excited about this new partnership to help veterans who need special care and extended care, identify those and get them into the available resources that the Veterans Administration has to offer. So these are just a few of the things that we're doing for our seniors. Astro?
Thank you so much, Dr. Ramirez.
Oh, you're welcome.
Yes.
I'll take any questions or any comments.
Great. What we will do, I will take some questions at the end of the presentations so that we can give our aging networks as well an opportunity to respond. So for those of you on the call, feel free to send your questions. So thank you so much, Dr. Ramirez. You guys are doing so much wonderful things, even in your community health center. And what is really great is that we recognize that the collaborations is one of the things that makes that possible for good senior health. So I would like to, at this time, I do want to acknowledge a couple of other folks who are on the line, and I have to just thank them before I announce the next speaker. So first I would like to also thank our administrative on aging and administrative and community living partners who have really worked with us feverishly over the last couple of months to make sure that we have to continue to strengthen these collaborations. And that's in the leadership of the Assistant Secretary Kathy Greenlee, Rick Nichols, Greg Case, Michelle Wasco, and many of at the team there. We also have on the line Ms. Kathleen Ode, who is the regional administrator for all of those of you here in regions 2 and 3. And then I would also like to recognize the HRSA individuals who, without this corporate agreement, this opportunity would not exist. So I would like to thank Tiffany Smith, who is the branch chief at the Office of Special Populations, and our project officer, Lieutenant Commander Kevin Bates. So as we have, as I have mentioned before, ACL and HRSA have this ongoing partnership that they've done for many years. And one of the strongest partnerships that came out of us, out of the aging networks on a more local level and working with the community health centers, is that of the partnerships of our national aging networks. There are many of them, but I am particularly delighted to announce the National Council on Aging. And so they have worked diligently with us on many webinars, monographs, and so forth to help the health centers understand what's available in terms of resources and how they can strengthen a collaborations with the aging networks serving their senior patients. So to represent NCOA, we have Sue Lachenmeyer on the phone. And Sue, thank you so much for all that you have done in terms of helping us better understand nationally how we can connect locally to the aging networks. So, Sue, without further ado, I would like to turn it over to you to give a brief overview of how the aging networks are working with the community health centers to strengthen these senior health. Thank you.
Thank you, Astral, and it really is exciting to be on this call. I think it's wonderful that you've really brought both the federal agencies together as well as local folks, and so I'm delighted to be on the call. And first, let me say that I actually formerly was in New Jersey. I lived in Hunterdon County, so Rena, it was very exciting to hear all of the services that are available through your FQHC for folks in what we really do know is a very rural part of New Jersey, hard as that is to believe. So what I really wanted to do this morning was to give you a very brief overview, and I'm really speaking on behalf of resources that are available through the Administration for Community Living, Administration on Aging, as well as the National Council on Aging. And I hope that you can take this information and really reach out and begin those partnerships with the Aging Network. I think you're, as FQHCs, they're really very well aligned. You're serving many of the same populations and certainly can become a resource to each other. And, you know, just as we start, I know that Astral gave you some figures about the numbers of older adults in the various areas now, but recognize that this aging population is going to continue to grow. Nationally, we are at about 60 million older adults, 60 and older, but by 2020, that number will be nearly 80 million. So again, potential clients certainly for FQHCs and clinics. So just a quick background on both the National Council on Aging and the Administration for Community Living. The National Council on Aging is a nonprofit service and advocacy organization, and our mission is to improve the lives of millions of older adults, especially those who are vulnerable and disadvantaged. And the Center for Healthy Aging within NCOA is the National Resource Center for the Administration on Aging. So that's where our partnership is together. Just quickly to let you know, the Center for Healthy Aging here at NCOA really is focused on improving the health and reducing disability among older Americans. We collaborate with diverse organizations really around a national movement. We're looking to identify, translate, and disseminate evidence on what works. We promote community organizations as really critical agents for improving the health of older adults. And we work with those community-based organizations and the Aging Network to reach and engage diverse elders, including those who are most vulnerable. In addition, we advocate for support for strong and effective community programs. The Administration for Community Living, Administration on Aging, is really, AOA is one of the organizations under that ACL umbrella that includes also the Office on Disability and the Administration on Developmental Disabilities. AOA's mission is to help older adults maintain health and independence in their communities, and it's now expanded to include individuals with disabilities of all ages. So I think you can see clearly how, at the national level, these two agencies are so closely aligned with the missions and purpose of FQHCs and community health centers. So just a little bit of background. The Older Americans Act was passed in 1965 in response to concern about a lack of community social services for older adults. The Act created the Aging Network to provide services for community-dwelling older adults, and it established the Administration on Aging as the federal agency that's focused on older persons. And it is an incredibly wonderful resource. As Rena was talking about all of the partnerships that she's working with at the local level, I want to give you just a highlight of this network that is working in parallel that many of you may not have connected with. So at the top really is the Administration on Aging, which supports 11 million older adults and their caregivers. Within that, there are 56 state units on aging. So one of the places you can go to immediately is to your state unit on aging, which is within the Department of Human Services. There are 629 area agencies. That's in New Jersey. It may be residing in the public health or in a separate unit, but you can certainly check state unit on aging and find the location of your own state unit. Under those state units on aging, there are 629 area agencies on aging and 246 tribal organizations. In New Jersey, they're county-based, but in many other states, they're regional, so they do diversify. But under those area agencies on aging are over 20,000 service providers and 500,000 volunteers who are working to deliver services for community-dwelling older adults. This network provides services and supports to 1 in 5 seniors. Some of the services are meals, rides, transportation, hours of personal care, caregivers who are trained and assisted, case management, and many other services. So again, what a remarkable resource for you. Within that system of the Aging Network, there are what are called Aging and Disability Resource Centers that really are generally partnered with the AAAs, or they may be one of the area agencies on aging. And they really have a no wrong door philosophy, providing person-centered, integrated services. So through that ADRC, information and referral, options counseling, and then the services that are referred to include Alzheimer's and caregiver supports, evidence-based programs such as the Chronic Disease Self-Management Program. We're going to talk a little bit more about that shortly. Benefits counseling, meals and rides, as I mentioned, the Veterans Home and Community-Based Services Program, care transitions, which is transitioning people out of hospital, rehabilitation, and nursing home care. So you can see that there are many touch points where FQHCs and clinics could be working with the Aging Network. And so I want to shift gears just a little bit and talk really about healthy aging, which we really understand as being more than a program. We really are looking at healthy aging as a systems approach. So programs like Stanford's Chronic Disease Self-Management Program and other evidence-based programs are supported through the Administration on Aging. These evidence-based programs provide tools that deliver health benefits to participants and change systems so that older adults can become activated self-managers. So the Administration on Aging, with NCOA as its Technical Assistance Center, has been working with these state units on aging and the Aging Network over the last several years. During the last 2 years, there were 47 states, Puerto Rico and the District of Columbia, that were funded under some ARA stimulus funds, and they reached nearly 75,000 completers, over 100 participants in the Chronic Disease Self-Management Program through March of this year. In addition, they were really working to strengthen a framework, a delivery system that really could coordinate efforts for optimum health and quality of life for older adults and maximize the use of proven self-care management services. Just quickly, some of the other evidence-based programs in addition to the Chronic Disease Self-Management Program are evidence-based physical activity programs, several other self-management programs, some for diabetes, for pain management, for HIV management, online programs, caregiver programs, depression management and behavioral health programs, fall risk reduction programs, and medication management. So again, a wonderful complement to the clinical services that are provided by the FQHCs and clinics. Just wanted to give you examples of some of the exciting work that we are doing in partnership with FQHCs. For example, this Chronic Disease Self-Management Program we see as a key piece of patient-centered medical home recognition and in meeting those critical NCQA standards. The new version really reinforces the critical role of patient self-management and the practice of self-management support. And within that patient-centered medical home clinical record, there are requirements to document the patient's self-management capabilities and to document their goals, to be able to demonstrate that you're providing tools and linking to community resources. You need to be able to counsel on healthy behaviors and assess and provide and arrange for mental health and substance abuse treatment, as well as providing community resources. So again, where we see wonderful alignment of evidence-based programs, and in particular the Chronic Disease Self-Management Program as a key component of patient-centered medical home standards, is really under these various areas, certainly in the use of data for population management. The Chronic Disease Self-Management Program is actually available in 21 languages. When we're speaking about individuals for whom English is a second language or limited or no English speaking, this is a wonderful way to reach them to build skills. Again, that documenting and assessing individuals, linking them to resources, the supportive care, self-care process really is a key piece under the PCMH4, which is providing self-care support and community resources. And that's really a must-pass criteria under those standards. So again, just quickly, we've been doing a number of initiatives. As Astral indicated, we did a webinar that is available on the, Astral's website around this very initiative, helping to integrate the chronic disease self-management within the electronic record and working with providers in clinics. And then another initiative that I think you might be very interested in is the Diabetes Self-Management Initiative. And in this opportunity, the AAA, the Area Agencies on Aging, the AAAs, partner with FQHCs and other clinical providers of services to get diabetes education accredited by either the American Diabetes Association or the AADE for Medicare reimbursement through either the DSMT and the MNT benefit. It's a lengthy process. I don't want to understate the challenges that there are in making these linkages, but it is an opportunity for direct reimbursement through Medicare to be accredited. Then the program includes the Stanford Diabetes Self-Management Community Delivered Program. Other components really include an advisory group to promote quality, instructors that have regular continuing education, and it is overseen by a registered nurse, a registered dietitian, or a pharmacist. And that, again, includes an individual assessment and education plan and personalized follow-up plan and continuous quality improvement. So, again, another opportunity where clearly area agencies on aging and community health clinics can partner around delivering a skill-building resource for individuals who have diabetes. Just briefly, toward the end here, I wanted to let you know a number of the resources that are available through the National Council on Aging. We also have a Falls Free initiative. This really is also done at both at the state and local levels, helping to raise awareness of the critical need for falls prevention, helping seniors in terms of identifying gait problems, referring them to evidence-based programs to reduce fall risk and falls. So again, that's one great opportunity for you. Another opportunity is really looking at our website, where we have numbers of lessons learned, a lot of best practices, more information on all of these evidence-based programs, lots of tools, an online community. Again, we do webinars monthly as well that are certainly open to all of you. And to recognize that the NCOA and AOA are really federal partners along with CDC, with HRSA, SAMHSA, CMS, really around focusing on bringing quality health and health care to older adults. So with that, I'm going to stop and just quickly share with you that I do have resources in a slide deck, and I will be sharing those with Astral. So if you need more information about where to link to services, you will be able to get that. Thank you.
Great.
Astral?
Thank you so much, Sue. Thank you so much, Sue. We really appreciate that. And I will like to open the line now to Kathleen Owen, who will just give you, just for a few minutes, Kathleen, as the Regional Administrator for Regions 2 and 3. Okay, I am not so sure we're getting to connect with her. So what we will do is, I do know she's actually on the call, and she was actually planning to just address all of you to let you know about the strength of this collaboration in your regions. Also, I want to just go through some acknowledgement of a couple of websites that you may want to note in terms of learning more about the collaborations and in terms of the resources that are available for both the health centers and the aging networks to provide that support for the senior health. So again, as we are through this national corporate agreement, if you visit us at www.healthandtheaging.org, all one word, as well on the you can also go to HRSA.gov and connect with resources there as a community for community health centers. In addition to that, we have off the AOA.gov website, there are a tremendous number of resources to actually as well support elder care abuse, which we do see a lot in our senior populations in the communities that the health centers serve. N4A.org with their locator, the elder locator, that has been a phenomenal system for many of our grantees who have been able to connect their seniors to health care services. And then NCOA.org, as you've heard from Sue Lackenmeyer, they have a tremendous number of resources that are available for you as well. I do want to mention that next April we are planning to have a national conference on aging in April 2013 in the Washington, D.C. metropolitan area. So please look out towards seeing those announcements. We are going to have our annual symposium around the same time that the NCOA will be holding one of their meetings as well. So it's a great, phenomenal opportunity for our aging networks and our health center programs to connect directly. So please visit our website. Feel free to sign up for our email updates and alerts, and then you will be informed as we get through. I do believe Kathleen Oates now can join us on the call. So Kathleen, if you're on the call and you would just like to say hello. Okay. All right. So what we will do is, I'm sorry about that, Kathleen, but I know she's also going to join the call that we're having for Region 1. But again, for all of our regional partners and whether they're from the health center side, from the primary care associations, to our aging network partners, we really, really are grateful for all that you're doing to bring all of our collaborations together. At this point in time, I'm going to take any calls or questions that some of you may have. Unfortunately, I think we're having a problem on the main line to unmute the line. So some technical difficulties, but if you would like to quickly email me any questions, we'll be happy to address them either directly here on the call or later. And Rena, as you were talking about the health centers, thank you so much for identifying some of the challenges that you have been having, as well as how you've worked with some of the successes. But there is one question. There is a question that we would like to ask. Mental health has become a very critical issue, especially for many of the community health center programs. And some of the grantees would like to know as well, how have you reached out to any of the aging networks to support you in providing that mental health part of your care, or is it strictly done at this point in time through your health center program?
That's a great question, and that's something that I just touched on briefly with the isolation and depression, but it is a big issue for our seniors, for a lot of our patients, and especially our seniors. We are very fortunate that we have wonderful county organizations. There's a Morris County mental health organization who is very supportive of patients with seriously mentally ill issues, as well as the local hospital. St. Clair's is one of our safety net for the patients who really need psychiatric help and assistance. There are some limitations. The lack of bilingual staff is always an issue, and so we partner with them in the best way that we can. And we're always looking for solutions to help our patients. We have had a primary care-based behavioral health services here, not to take care of the seriously mentally ill, but to take care of temporary or situational issues, like you mentioned, if we are concerned about elder abuse and things like that. And we have a bilingual licensed clinical social worker on site. It is a very, very small piece of what is really needed, and I will definitely be looking out for connections with aging networks in the area to see if we can get this strengthened, because this is a service that is so completely needed.
Wonderful. Thank you so much for addressing that as well. And then we have been asked, in terms of the patient-centered medical home model and creating that medical home model, are there any other opportunities that the aging networks may be able to support you as a health center grantee in further meeting those needs in your medical home model?
Well, as Sue mentioned, the chronic disease case management program and the Stanford program is something that we have used and have had some of our patients become trainers and facilitators, as well as some of our staff. And that's something that's a wonderful idea, to begin to grow that and integrate it even further into our PCMH so that it boosts boosts and enhances the self-management piece. That's something that we've always been very, very pro self-management, because we feel the patient needs to have the tools to take care of himself the 24 hours and or all of the days that he's not at the center. So having that's a wonderful tool, and we'll expand it and use it so that we can really address the needs of the patients and help them get the self-management tools that they actually really need in order to manage complex conditions or to remain healthy and to remain active and to combat isolation and depression. So that's a wonderful piece that can be incorporated into our PCMH transformation. Supportive services, again, is another wonderful piece, because I think we need to really have a team approach. PCMH is a team-based approach to serve that patient where the patient is at. And this is the most important thing. We always have to remember that. That's in our mission statement, and that's what we do every day. So all these resources that were explained, that Sue explained, and I'm looking at now on the website are just absolutely tremendously beneficial. And they will become part of our practice and our PCMH.
And Rita, I
Wonderful.
think adding the AAAs as one of your key resources, as you were speaking, I just want to share that the AAAs really at the county level there in New Jersey, but at the regional level, wherever you are in your state, really are an information and assistance access point for individuals who are not likely to be at a critical point. They may be, where they may need to be referred to for clinical services. But the other key here is that to engage people and get them both aware of the aging network system, but also aware of clinical services that are available through the health clinics, the FQHCs, at an earlier time, so that those who don't already have a medical home really can be linked to those services.
Absolutely. Absolutely. Thank you. That's great.
Absolutely. And I think that is critical, Sue, as you correctly said at the end. It is the mutual relationship. Not only will the health centers really benefit in the information that's being shared, and as you've heard that firsthand from Rena as well on a call today, but also it's a phenomenal opportunity for seniors who have no medical home to be linked to it. And we know that through a lot of the aging networks, a lot of times many of the patients that are discharged from hospitals, they get case management through the aging networks, but I think it's a phenomenal opportunity to refer them to follow-up care, to the health center programs that can continue to provide that clinical support they're needed, so that overall it impacts, not only makes it more cost effective on the entire healthcare system, but also it's truly an opportunity for seniors to be linked to primary and preventive care that can avoid so many preventable type cases. So we do know, even right now in our conversations, we are working closely to really look and identify how some of the health center programs can receive medical reimbursement through CMS in some of these services. And I know NCOA has, on several of their webinars and several of opportunities with us, have really reached out to how some of our health centers can actually connect and get that reimbursement, which programs they may be tied to and which ones they potentially can be tied to in the future. So that whole, the whole mutual relationship between the aging networks and the primary care and preventive care services are so critical to providing that care. And we know we are only touching the surface of what we need to do nationally. And what we are hoping to accomplish, even in your regions here in 2 and 3, is that we hope that through the partnerships and the collaborations, and for those of you on the aging network side, you have an opportunity now to work, know how you can support your health centers. And from the health centers, you now know there's another resource there that's available to you to support it. So we hope that these number of patients that we see, the 300,000 plus currently being seen in the community health centers in regions 2 and 3, will probably triple over time. But what is really great to know is that prevention is one of the most important key strategies that we must all do in terms of healthcare to provide better quality care for seniors. And so for all of our health centers on the call today as well, we want to thank you from our partners who are our primary care associations. We thank you for what you do for these community health centers, and we are going to be working with our PCAs, especially the ones in your regions, to provide webinars and joint opportunities where you can learn more about what's happening locally. And for all of our aging partners, whether you're federal or local, we want to thank you again for all of your support to providing the additional support for the FQHCs or the health center programs. So what I will do now at this point, Sue and Rena, I don't know if you have any final comments at this time. And I'm not so sure if yet we were able to connect with Kathleen.
Go ahead.
Okay, great. Great.
This is Sue, and I do want to... Sorry, Astral. This is Sue. I just wanted to say we do have resources. We think partnerships are really what will help to strengthen both the aging network and certainly can be of benefit to the community health centers as well. So we look forward to new opportunities.
Wonderful. Thank you so much. So I would like to wrap up and say, again, thank you to all of our participants who have spoken on our calls today. I want to thank ACL and HRSA for this partnership, this tremendous partnership that they have been working over the years, and for thank HRSA again for funding this corporate agreement as we continue to provide that training and technical assistance to help our health centers really improve the quality of care and access to seniors across the country. So thank you everyone for today's call. Please let your colleagues know, the ones who were not able to join the call this morning, that the call will be archived on our website at www.healthandtheaging.org so that they can learn about the collaborations occurring right now in Regions 2 and 3. So thank you, everyone, and have a pleasant day.